2021 education thinking or education session, forward thinking about posterior circulation. And so this is the first part of a 6-part series that we will be doing this fall on posterior circulation stroke. And we're very excited to share this session. We had over 120 participants registered for this session. This session, it will be focusing on recognizing posterior stroke syndromes to facilitate timely access to hyperacute assessment and treatment. As you have seen, this Zoom workshop is being recorded and will be posted on our Central South Regional Stroke Network public-facing website. If you do not wish to be your name to be recorded or your face to be recorded or your name identified, please turn off your camera and de-identify your name on the screen. This session is going to focus on the assessment and management of posterior circulation. And I would like to thank the planning committee for putting together not only this session, but our series. So Vicki Jones, Aileen Woodley, Chris Pollard, Elke Hilgendag, Candace Coe, Carmen Carmazan, Allison DeHaan, Janice Power, Joseph Morgan, Amy DeHook, Tammy Tebbett, Kathy McVeigh, Charmaine Martin, Leanne Kent, Barb Cabelius, Eileen Britt, Stefan Peluso, and myself. This session is really focusing on discussing case scenarios to recognize posterior stroke syndromes, focusing on the various symptomatology, how to recognize and identify and assess these syndromes to promote timely access to intervention, to discuss the hyperacute assessment and diagnostic workup for posterior circulation strokes, and to discuss the Canadian best practices for hyperacute treatment of posterior strokes with thrombolysis and mechanical thrombectomy. I am we have two amazing speakers with us this afternoon. The first speaker I'm very happy to introduce is Dr. Aris Castanos, a neurologist at Hamilton Health Sciences. He completed his stroke vascular neurology fellowship at McMaster University. His academic focus is on the evidence-based evaluation of novel therapeutic approaches on acute stroke treatment and secondary prevention. His research study on optimal blood pressure management after endovascular stroke treatment, DETECT, is sponsored by the Canadian Institute of Health Research, Population Health Research Institute, and a new investigator from Hamilton Health Sciences. So welcome, Aris, who is going to be our first speaker.
Thank you, Rhonda, for the kind introduction, and thank you everyone for joining in. I'm now sharing my slides, and I hope that everyone can see. I'll go also into presentation mode. And this should be let me find where it is.
There's going to be a slideshow.
Yeah, I'm trying to find where the slideshow is. I think I found it previously.
It's just a couple of slideshow over beside tools at the top and the top toolbar.
Oh, it's over here. Oh, sorry for that. I had some technical difficulties and I'm not really familiar with this program over here. And yeah.
There's, if you move over, if you see slideshow at the top.
Oh, here, right? Start from first slide. Okay, that's here. Okay. So We're going to talk a little bit about the diagnostics and posterior circulation syndromes. I have some disclosures which are academic, the support that Rhonda just mentioned. But my biggest acknowledgement is that I have been tricked by symptoms suggestive of posterior circulation strokes. And I think all of the neurologists, we have been tricked with many of our patients thinking that this is a stroke and turned out not to be a stroke, or the other way around. So you can see my slides advancing, right? Okay, excellent. So a case from last week from the Hamilton General Hospital, the stroke unit, a 60-year-old woman with history of hypertension, asthma, anxiety, GRD, CKD, and orolingual cancer treated with chemotherapy and radiation therapy 7 years ago, was transferred to D in a periphery hospital due to ongoing vertigo, nausea, and vomiting. As she didn't pass the act fast, she wasn't transferred to us, and she was outside of the window for any intervention at the time. So patient reports that she experienced acute onset of posterior neck and occipital headache before her presentation to the hospital. The occipital headache started suddenly while she was sleeping and woke her up in the middle of the night. She tells us that she was suffering from tension type headaches, but this headache was different both in intensity and in characters. She took some painkillers, but the next day she tried to get out of the bed, and she notes that she had severe imbalance and unsteadiness, and she had severe ongoing vertigo, nausea, and emesis. She experienced no visual symptoms, no diplopia, no numbness or limb weakness. Because she didn't improve, she called the EMS and sought for medical attention. So on the examination, when she presented in the ER, right-sided ataxia was noticed and left-bodic horizontal nystagmus with hypometric saccades. So looking at this history, you can identify some red flags: the acute onset of the symptoms, that the headache woke the patient from the sleep, the severe imbalance and unsteadiness for a previously healthy woman, which was like independent and walking, and the right-sided ataxia and hypometric saccades, which are like focal neurological deficits. So non-contrast CT uncovered this hypotensity in the left cerebellum consistent with a stroke. The DWI and the MRI uncovered also bilateral lesions, so a lesion also on the right cerebellum, which was not evident in the first CAT scan. And in the CTA, we can see where the arrows is, that the vertebral arteries are missing because they are blocked, and that's potentially the cause associated with your stroke. So first, we're going to present about the challenges in the diagnosis of posterior circulation stroke. So about 1 out of 4 of ischemic strokes in United Kingdom, they affect posterior circulation brain structures. So this is nothing that is really uncommon, it's relatively common, and we see it in our everyday clinical practice. And early recognition of posterior circulation stroke or transient ischemic attack may prevent disability and save lives. But the challenge is that it's difficult to recognize and treat effectively compared to the strokes in the anterior circulation. So delayed or incorrect diagnosis may have devastating consequences for the patient, including potentially death or severe disability if acute treatment, which Dr. Hawks is going to talk about, or secondary prevention is delayed. So although the risk in posterior circulation ischemia, we thought that, having a recurrent stroke if you have a TIA or a previous stroke is low and lower than anterior circulation ischemia. Newer evidence suggests this is not exactly correct. The risk is as high, if not higher, by recent studies. So this is a very nice paper that just came up like a week or two ago. Is from the UK registry, and they are, they are discussing about the non-consensus TIA. And by meaning non-consensus TIA, we are talking about those transient ischemic attacks that they're not the ones that we are used to. The ones with the dysarthria, with the facial droop, with the arm weakness, with the leg weakness, or the sensory deficits. So we are talking about patients that present with vertigo only, or only ataxia, or only diplopia that lasted for an hour or so and then resolved, or patients that present with only dysarthria. And as you can see in the table below, this non-consensus TIA, these untypical TIAs, they are much more common in posterior circulation compared to the anterior circulation. So why should we care about these non-consensus TIAs? The thing is that we are not really good at recognizing them compared to the classic TIAs, and less probability of those patients getting appropriate medications for secondary prevention. And you can see here in the graph that when we compare the classic TIA symptom patients present with classic TIA symptoms versus the ones that they present with this non-consensus TIA, they have a similar risk of stroke risk. And you can see that goes up to 10% within the first 3 months after the first TIA event. So posterior circulation stroke is indeed a challenging diagnosis. It has been estimated that more than 150,000 strokes per year that they are misdiagnosed in the US emergency departments. And posterior strokes are 3 times more likely to be misdiagnosed compared to the strokes in the anterior circulation. So according to the New England Medical Center Posterior Circulation Registry, the most common symptoms is dizziness, unilateral limb weakness, dysarthria, headache, nausea, and vomiting. And the most common signs is gait ataxia, unilateral limb weakness, and nystagmus. And we have the rule of 5D. So 5D stands for dizziness, diplopia, dysarthria, dysphagia, and dystaxia. And the more these one of our patients has, the more likely that he has suffered from posterior circulation stroke or TIA. First of all, because we are talking a lot about vertigo, we need to clarify what we mean exactly by vertigo. So by vertigo, we mean the strong sense of motion or spinning. Either we see the environment spinning around us or we feel that we are spinning inside the environment. This is not the same as disequilibrium, being feeling off balance and unsteady or not really in the baseline. And this too can be either coming from the brain or from the ear. And that's a totally different story from lightheadedness or pre-syncope, which is caused by cardiac issues or other systemic issues. So the question is the vertigo due to the stroke? So some red flags is that if we have acute spontaneous onset of vertigo and imbalance, we should think about it. If we have a patient that was able to mobilize and he cannot walk anymore, we need to be really careful about that. And a very interesting point is that in some stroke syndromes in the brainstem, we might have acute hearing loss. So vertigo associated with acute hearing loss, we should be really careful and do a proper neurological examination and not assume by fact that this is coming from the ear. New or unusual headache and other central symptoms or sign as hiccup, dysarthria, a Horner, or mild long tract sign, which we are going to discuss later on. So in the Chinese registry, here the investigators, they found that the signs with the highest positive predictive value, meaning that if your patient has the signs, it's very likely that he has a posterior circulation stroke. So if your patient has cross-sensory deficits or cross-motor findings, meaning facial droop on the right side and arm-leg weakness on the left side or vice versa, or he has a third nerve palsy or chondrodynopsia, it's really likely that this patient is suffering from a posterior circulation stroke. However, there is a low sensitivity, meaning that if your patient doesn't have these findings, it doesn't mean by default that this patient is not suffering from a posterior circulation stroke. So I'm going to discuss a little bit about the posterior circulation, about the anatomy, and some mechanisms that are associated with strokes in the posterior circulation. I'm not going to go much into detail. It's a huge topic, but we need all to be clear the structures that the posterior circulation is applying, which is the thalamus, the hypothalamus, the mesial and posterior temporal lobe, the occipital lobe, the brainstem, the cerebellum, and the upper spinal cord. So it's, as the word says, the posterior part and the down part of the brain. So we have some vessels which are really significant and we should know them. We have the vertebral arteries. You can see them highlighting in blue in the picture. The right one is a diagram and the left one comes from an MRI from a patient. The intracranial vertebral arteries, the basilar artery, and the posterior cerebral arteries, and of course all the branches, all these little things coming off from these major vessels. So I'm going to talk a little bit more about the vertebral artery anatomy, and I will let you know why I like to highlight a little bit more about the vertebral artery anatomy. So the vertebral artery takes off from the subclavian artery, and this is the V1 segment, then runs into the transverse foramina from C5, C6 until C2, and this is called the V2 segment. Then it takes a loop around the atlas, and that's called the V3 segment or atlas loop segment. And then it goes intracranially, piercing the dura, and this is the V4 segment, and joins the other vertebral artery to form the basilar artery. So the causes of posterior circulation strokes, the most common cause is embolism. And the embolism can come either from a vessel, which is down from where the embolism, the vessel was occluded. So it can be either due to atherosclerosis or dissection, or it can be due to any cardiac source. Large artery occlusive lesions are found in a third of patients, and another third of patients, they have in situ small vessel occlusion, so lipohylenosis, small vessels because of hypertension, they clot and they cause the stroke syndromes, or other unidentified mechanisms as vasculitis or dolichoectasia. So I'm going to discuss a little bit about vessel stenosis. So it's significant to understand and find out patients that they have vessel stenosis in the posterior circulation, because these patients have a threefold increased risk of stroke in posterior circulation after another stroke or a TIA. So here you can see a DSA on the right side of the screen, a CDA on the left side of the screen, and a carotid ultrasound depicting stenosis in the vertebral artery of a patient. So dissection is another thing that we need to be mindful about. So we say that dissection can be a result of a trauma, but in fact, most of our patients, they don't have a clear history of trauma. And the most common symptoms is vertigo, headache, and neck pain. And we have one case over 100,000 per year. And the complications is, of course, stroke, cerebellar or brainstem infraction, and we're going to discuss about the syndromes, subarachnoid hemorrhage, so that's a cause and rather unusual cause of subarachnoid hemorrhage that we need to think about, and also vertebral artery pseudoaneurysms, which can lead to compressor neuropathy of the cranial nerves. So it is estimated that vertebral artery dissection is a significant cause of strokes in patients at younger ages and can be as high as 10% or up to 25%. So from a registry that you see here in Switzerland, the mean age of the patients was 43 years of age, 15% they had bilateral vertebral artery dissection, 8% were just asymptomatic and they were found out because they were just screened. Presenting clinical symptoms, ischemic stroke in the majority of them, TIA in 10% of them, occipital headache or neck pain in 12% of them, subarachnoid bleeding in 2% of them, and an unusual presentation, which is sensory motor cervical radiculopathy in only 1%. So in patients that they have a stroke and vertebral artery dissection, we need to be really careful and look for signs of subarachnoid bleeding in brain imaging. And this is really important because these patients cannot receive TPA. Another point is that patients usually complain of occipital headache and neck pain, so this is really common. And some of the patients, like a minority, they report like something as a pulsatile tinnitus that they are experiencing. The NIH score can be as low as 1, like very minimal signs, or can be as bad as 35, which is the direct consequence of the vertebral artery, the clot in the vertebral embolizing upper in the basilar artery. So the interesting and the point that I need to highlight is that 13% of the patients before the stroke, they had a TIA, and the median time from the TIA to the stroke was just 1 day. You can see here that the range was just 1 hour up to 17 days. So we need to be really careful and find the patient with dissection that present with TIAs, because then we might be able to prevent the stroke coming in. And lastly, I'm going to talk about a concept which was one of my first interest as a resident in neurology, is vertebral artery hypoplasia. So it's really common. Most of us, we don't have symmetric vertebral arteries, and one is larger than the other one, which is totally fine. The thing is that we know that patients with vertebral artery hypoplasia, they are 2 times more prevalent to have posterior circulation ischemia compared to the ones that they don't. And the reason for that is that the small artery, because of low flow, is can be predisposes to prethrombotic and atherosclerotic processes. So you can see here that when time goes by, small atheromas form and they occlude the vessel finally. And the other is because of flow dynamics, the contralateral big left or right vertebral, the dominant one, attracts the thrombus. So a thrombus, instead of going to the MCA, can travel through the vertebral up to the basilar and give a really bad stroke. So I'm going to discuss about posterior circulation stroke syndromes. So this is a very interesting topic for neurologists. We have like multiple syndromes. We give different names. I'm going to go quickly through the major ones. and just present which are the most significant findings. So we have Wallenberg's syndrome, which is often the result of an intracranial vertebral artery occlusion, and is often missed or misdiagnosed. And the reason for that is that the symptoms you can see here, it's really unlikely to see them all in the same patient. So most of the times you will have an incomplete Wallenberg's syndrome. And the patient will have nystagmus, vertigo, diplopia, contralateral loss of vibration or proprioception, and ipsilateral loss of facial pain and temperature, dysphagia, dysarthria, ipsilateral dysmetria in terms of cerebellar symptoms, contralateral loss of body pain and temperature, and ipsilateral Horner syndrome due to damage in the ascending sympathetic fibers. So to understand these syndromes, we need to be very conscious about the anatomy of the brain. And you can see here that there are nuclei in the brain and ascending and descending fibers. And depending on where the lesion is, it damages those tracts and nuclei, and that's where the symptoms come from. Another syndrome, which is also relatively common, is the Medullary Syndrome. Affects is because of anterior spinal artery stroke. The thing about this syndrome is that it gives you hypoglossal nerve palsy, and gives you also contralateral hemiplegia and hemianesthesia. The next one is the lateral pontine syndrome. So we go a little bit higher in the brain, and is caused by an occlusion of the anterior inferior cerebellar artery. So this is a syndrome that can cause facial nerve palsy that looks like as Bell's palsy. So it's a peripheral nerve palsy, and in cases of a Bell's palsy that doesn't have the typical characteristics, we need to be really mindful and do a proper neurological examination to uncover maybe Horner syndrome, or like deafness or tinnitus, or cerebellar signs, or impairment of pain and temperature contralateral to where the facial droop is. Of course, we are not going to go and do MRIs in all patients with Bell's palsy because this is relatively uncommon, but we need to be mindful and do a proper neurological exam when we have some atypical presentations in patients with Bell's palsy. The medial pontine or foveal syndrome is due to the occlusion of the paramedian branch of the basilar artery. We can have intracranial nuclear ophthalmoplegia with a gaze paralysis, cerebellar signs, facial nerve palsy, and contralateral we get hemiparesis and loss of vibration and proprioception to the arm and the leg. We should be really mindful that if the damage is done only in the cerebellum, we can have only vertigo without any other findings, or to have very subtle findings, as you can see here, some like tinnitus or decreased hearing sensation, which can be really tricky. So we need to be really mindful about that cerebellar strokes can give only vertigo. And going a little bit upper in the vasculature, we are talking about basilar artery occlusion. So in the proximal basilar artery, we can have findings of the Wallenberg syndrome, plus or minus cerebellar signs. In the mid-basilar, we have the locked-in syndrome, which is mostly caused by local atherosclerosis, plaque building up through the years and through a lifetime. In the distal basilar artery, we get what we call top of the basilar syndrome, and this is most likely from an embolic cause. The clot travels all the way up to the basilar and gets stuck in the distal basilar, which is narrower. The interesting information here is that 50% of the patients, they have some precursory symptoms or a progressive onset, and the prognosis is poor if left untreated. And Dr. Hawks is going to discuss more about the treatment options and why is it really important to find those patients. So locked-in syndrome, you can see here that we have like the classical locked-in syndrome, that the patient is totally immobile and he can only blink and move his eyes. We can have incomplete with a minimum movement in one part of the body, and total locked in, conscious, but unable to move any part of the body. So this is a very interesting book. It's very hard to read. I wasn't able to complete it. It was about a 12-year-old boy that suffered from locked in syndrome, and describes how was this experience. Of course, this was not due to a stroke, it was another cause. And he describes how is living in your own body body and not being able to communicate with your beloved ones. So top of the basilar syndrome is really, really tricky because the clinical presentation can be really challenging. The patients can present with hallucination, behavioral changes, alternating level of consciousness, or even present with a coma. So the primary cause, as we said, is a thromboembolic occlusion of the distal third or tip of the basilar artery. It's often missed due to patient confusion and unawareness of visual deficits. It is important to distinguish in patients coming with a coma because we have some treatment options, and Dr. Hawks is going to discuss more about that. And the red flags here is the sudden onset of bilateral signs, including ptosis, pupillary asymmetry, or lack of reaction to light, and somnolence. So if you think that for a patient with acute or subacute onset of a coma, you find some focal findings, or you are really concerned about top of the basilar syndrome, let's go ahead and do a CTA to see if the basilar is open, because it's a potentially treatable condition. Going a bit higher to the posterior cerebral artery, we know that the PCA gives blood flow to the thalamus, and we're going to discuss in the next slide about the thalamic syndrome. It gives also blood flow to the occipital lobe, and the patients can present with homonymous visual field deficits. And it gives also blood flow to the medial and temporal lobe. And these are challenging presentations because the patients can present with verbal amnesia, alexia and visual agnosia, color anomia, visual amnesia only, or they can have prosopagnosia, meaning that they are not able to recognize faces. And here you can see three typical MRI of a patient with stroke. The first case is a thalamic stroke. The second one is in the occipital lobe, and in the temporal lobe, and the third one is in the occipital lobe. So going to the thalamic stroke, we should highlight that the thalamic stroke is a chameleon. So we have many presentations. Depending if the lateral territory is affected, we can get a sensory hemi syndrome, or even we can get like a painful syndrome or hemidystonia. So if the anterior part is affected, we get this abulia and confusion in the patients, which is really hard to diagnose and really hard to treat. If the paramedian part of the thalamus is affected, we have amnesia and vertical gaze paresis, and we can have also asterixis. If the posterior choroidal artery gets affected, we can have visual field defects, and we can have also dystonia and other findings in these patients. So a thalamic stroke is a chameleon. We should be really mindful about that and be really careful when patients with acute onset of when patients present with acute onset and neurological symptoms that they are not usual for strokes, but we need to keep stroke as in our differential diagnosis. So going to the occipital lobe, we're going to discuss about the Babiski Syndrome. So this is caused by bilateral bilateral hit in the occipital lobes. So the patients, they are blind, but they are not aware that they are blind. So you see a patient that, he's bumping into objects, and if you ask him everything is okay, he'll say, yeah, it's okay. And he will tell you a story which is totally doesn't make sense. So how we call that these patients, they are literally blind to their blindness. And another interesting syndrome is left occipital lobe with corpus callosum infraction that can cause the syndrome we call alexia without agraphia. So the patients, they are able to write, but they are not able to read the writings. So many of these patients, their first thought is, oh my God, my glasses are not working correctly. So they go in an ophthalmologist, and then they realize that it's not that they cannot see the words, it's that the words don't make sense to them. And the reason that is caused is because the corpus callosum is the communication between the right and the left hemisphere. So the connections between the visual input and the recognition of the words is affected. So we talked about stroke chameleons. that we should keep in our differential diagnosis. So if you see reduced consciousness level or global amnesic syndrome, always please keep in your differential diagnosis bilateral thalamic or single thalamic ischemia. If you see that the patient presents with a confusion or delirium, we should keep in mind for bilateral occipital stroke and maybe test the visual fields. If there is a vertiginous syndrome, it's highly uncommon, but we should keep in mind that patients that present with only vertigo could turn out to be a stroke. So they we have to be really cautious and check for nystagmus, and we're going to discuss about the diagnostic workup. And rarely brainstem ischemia, when it first comes into play, we can have bilateral rhythmic leg movements, and that's something that sometimes is misdiagnosed for a seizure. So except for stroke chameleons, we have also stroke mimics. So many patients that present with these symptoms turn out to have vestibular neuritis or labyrinthitis, multiple sclerosis, other tumors in the brain, CNS infections, or systemic electrolyte and other imbalances. So we have to be really cautious about the differential diagnosis. And if we are concerned, stroke should be one in this huge list of differential diagnoses. So I'm going to go into the next topic and discuss about the diagnosis of posterior circulation and TIA in the emergency setting. So there are differences in the anterior and posterior circulation, and the main differences is that FAST is not good enough to detect strokes in the posterior circulation. As you can see here down the list, we have like clinical signs and symptoms which are not really suggestive of a stroke, and which can be missed in the first assessment of the patient, and can be totally missed if we just do a screening with a FAST. And computer tomography has really poor sensitivity in finding strokes in the posterior circulation. So the 4 pillars for the diagnosis of suspected posterior circulation strokes when you first encounter them. First is history. You should take a very good history about the temporal association of the patient's symptoms. If they happened in like a sitting position, when did they happen, what was the patient doing, and take a very, very clear and history of any preceding events in the days before. Then we have to look for clinical signs. We have to look at the patient into the eyes, and I mean this literally, look the patient in the eyes and look for visual field deficits, eye movement abnormalities as nystagmus or gaze pulses, Horner syndrome, and also make the patient walk and look if he has gait ataxia. And we should be really careful about previously ambulant patients that they have an acute loss of balance. Stroke should always be in the differential diagnosis of these patients. These patients should not be discharged home, and we should always get MRI before discharging them. So talking about MRI, and we're going to discuss a little bit more in detail, MRI is the gold standard for posterior circulation stroke, but sometimes it can miss like tiny strokes if it's done too early in the presentation. So if you're suspecting that your patient has a stroke, a negative MRI is not good enough, and maybe you have to repeat it. As we said, the fast screening test is not good enough for posterior circulation strokes. There are some scales, as the recognition of stroke in the emergency room Rosier scale, which has a good element in this scale. It has integrated the visual field defects. So you score 1 if the patient has any visual field defect. The downside is that if the patient has lots of consciousness or syncope, and syncope is a bit more clear, but loss of consciousness is a bit wider, he gets -1 point, meaning that this patient is unlikely to suffer from a stroke. But as we said, basilar artery stroke can present as acute loss of consciousness. So what are the red flags and the visual manifestations that we should watch for? First, make the patient look into your eyes, and then move his eyes to the vertical and horizontal plane to see if there is any gaze paresis. Then look for ptosis, the eyelid going down, or miosis. Look at the pupil and look for visual field deficits. If there are any of these signs, then the patient has some damage in her or his brain, and MRI is the way to go. So there are some publications suggesting alternative scales for posterior circulation stroke when they are suspected in the emergency department. So here the authors propose that FAST can be augmented by using ataxia, testing for ataxia and visual disturbance. And they propose this FAST AV for ataxia and visual, or FAST AB, ataxia and blindness. But this is a small study, hasn't been replicated, so I cannot really tell you how good is this for diagnostic purposes and screening purposes. The ABCD3 score I has been suggested as an accommodation to the usual ABCD2 score, which is a score that we use for patients with TIAs. So ABCD3 I score is as ABCD2 score. It has 3 elements. It has, if the patient had a previous transient ischemic attack, he gets 2 points. You do imaging, and if this ipsilateral stenosis to the area of the brain that you are thinking might be affected, then you give the patient 2 points. And if the patient has acute diffusion weighted imaging, hyperintensity in the MRI, then he gets another 2 points. So the authors here suggest that maybe we can develop a similar score in the posterior circulation, incorporating features of vertigo, visual symptoms, or ataxia. And there is another score here that has been proposed. This Pci Risk Score has some elements, as you can see here, posterior circulation. The authors here, it's a small single-center study, so this has been not replicated. They say that it has a really good sensitivity, picking up those patients that they have a stroke, but really poor specificity. So going to the HINTS exam, I think you're most aware about the HINTS exam, and I don't see the videos playing. I'm sorry for that. Yeah, let me see. No, they're not playing. Sorry. So in the HINTS exam, you just ask the patient to look at your nose, and you turn the head quickly to the one and the other direction. And if the test is positive, meaning that this is not peripheral, the patient should be able to just stare at your eyes and not having catch-up saccade movements. Nystagmus, we should always look in patients that they have a vertigo for nystagmus. We move our finger to the right and the left. So nystagmus is involuntary rhythmic side-to-side movements. They can be up, down, right, left, or circular. We should be cautious when they are pure vertical and multidirectional, as we call the direction changing nystagmus. And this is a sign for central damage to the brain. Testosterone deviation is characterized by an acquired vertical misalignment of the eyes. So we do what we call the alternate cover test. So we cover one eye and then we cover the other, and we see if the eye is moving to the vertical plane. And there is a very nice hint here. If the one eye is down and the other is up, we draw a line, and then we move the line to our maps of the brainstem, and we can make a hypothesis based on the rest of the neurological examination where the lesion might be. So the HINTS exam has the head impulse test, nystagmus, and test of Q. So it's really concerning for a stroke if the head impulse test is normal, so the patient is able to look at your nose when you're turning their heads. If there is direction change, nystagmus or vertical nystagmus, and if there is skew deviation when you assess the patient. So there is a study that I'm sure that
because I was driving, so I just put it here when I was like, but the way it talks, it goes blah 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 blah. I can't. I'm not shutting up. Whatever.
Yeah, so this is a publication that most of you, I think you're familiar about. So the interesting thing about here is that patients with central central damage to the brain, they can have acute auditory symptoms. They can also present with headache or neck pain, as patients also with peripheral causes. And skew deviation or untestable alternate cover testing can be present in 4% of the patients with peripheral cause of vertigo. So interesting again is that general neurological signs, they are specific, meaning that the patient has damage to the brain, but they are not sensitive. So if you don't find any neurological any focality in your neurological examination, it doesn't mean per se that the patient has not a stroke. And the initial MRI with WI can be negative in patients with stroke. So if the patient has a dangerous hint, as I say here, so it's a hand impulse test that is normal or untestable. If the nystagmus is present and is direction changing, or if there is Q deviation, then you should be really mindful that this patient has had a stroke. So the caveat to this publication is that these tests were performed by neuro-ophthalmologists. So because I was trained with one neuro-ophthalmologist, these guys are really amazing in differentiating between the different types of nystagmus, and they have greater validity of doing this test. However, in the real world, in a meta-analysis, it seems that HINTS is doing pretty well. So there is a pool sensitivity of the studies published so far of 95% and specificity of 71%, which is pretty good. And in other publications, it's found that HINTS is able to outperform the ABC2 score when we are thinking about acute vestibular syndromes. And interestingly enough, it outperforms MRI obtained within the first 2 days after symptom onset. So if you have a positive HINTS exam and the MRI is negative, just keep the patient and do another MRI in 48 hours, let's say. So a HINTS exam only if nystagmus is present and only if vertigo is there all the time. So if nystagmus is coming and going, or if the patient experiences symptoms when he's changing position, then distal bike is the way to go. As you know, the maneuver, you turn the patient's head and then you drop him in the bed and you look for nystagmus. So there should be a lag between dropping the patient down to the bed and the initiation of the nystagmus. And if you see this clinical picture, and then when the patient gets a nystagmus, he complains that I get really dizzy, then he can be quite reassured that this patient might have a benign paroxysmal positional vertigo. Of course, nothing is perfect. Things can happen and things can mimic. But if the exam is exactly the way I described with this lag in the symptoms of vertigo, then you can be quite reassured. So the imaging for suspected stroke in posterior circulation, as we said, MRI with diffusion weighted imaging is the way to go. It's far more sensitive than CT in the diagnosis of stroke in the posterior circulation. False negatives can occur with MRI, and some publications report that they can go up to even 19%. And MRI with fat saturation can be used to uncover patients with vertebral artery dissection. There is an interesting publication saying that if you get non-contrast CT and you add CT perfusion on top of that, maybe you can enhance your your likelihood of diagnosing a posterior circulation stroke. Please be mindful that CT perfusion is only positive when we have a large vessel, a vessel occluded in the brain. So for lacunar strokes, as you can see here in the red square, that they are mostly in the pons and midbrain. Because we have small vessel occlusion, we'll not have any findings in the CT perfusion. So if CT perfusion is negative, it doesn't mean that our patient doesn't have a stroke. And of course, he has a symptom suggestive of a stroke. Ultrasound can also be quite helpful, and I'm providing here an example is this subclavian still syndrome, where the subclavian artery occluded or severely stenosed proximal to the origin of the vertebral leads to a reversal in the direction of flow in the ipsilateral vertebral artery. Sometimes this can be all the time. Sometimes it can happen when the patient is using the arm, and because he's using the arm, the muscles need more blood, and blood is coming from the reversal of flow to the vertebrals. So ultrasound is a really cool way, first of all, to see if the artery is reversed, and to do as we call the cuff test. So you inflate a cuff, causing transit ischemia to the limb, and then you deflate and you see the reversal of flow in the vertebral, which is a pretty interesting thing to see for a patient that presents with posterior circulation TIAs when he's using his left or right arm, and the history is pretty concerning for subclavian still syndrome. So going to the conclusions, and I'm looking forward to your questions and further discussion over the next minutes. So the diagnosis of posterior circulation ischemia is based on rapidly developing clinical signs of focal mostly disturbance of cerebral function with no apparent cause other than that of vascular origin. So meaning if your patient has acute onset of neurological dysfunction, then or acute onset of symptoms that can be explained by stroke, be really mindful and please exclude that the patient is suffering from a stroke or a TIA if the symptoms have been resolved. Evaluation for the presence of nystagmus, visual field defects, and lip ataxia should be performed in all patients with suspected posterior circulation ischemia. So if you're suspecting posterior circulation ischemia, fast is not good enough. Look the patient into the eyes and do the test that you have to do and make the patient walk. So any episode of unusual headache and coupled with sudden onset of vertigo or imbalance should be thoroughly investigated to exclude a posterior circulation ischemic event. So we need to be really cautious about these patients. And as I said, do not discharge a patient that was previously independent and now he's in the stretcher and cannot get out of it because of vertigo. Unless, of course, if you have a very good explanation for that and an alternative diagnosis which has been established. Evaluation with MRI is the gold standard and should be performed in all patients with suspected cerebral ischemia. Of course, all gold standards are not perfect. And if you are suspecting that the patient has a stroke, if you're not able to find an alternative diagnosis, the patient should repeat the MRI in the absence of an alternative diagnosis. Patients presenting with decreased level of consciousness, if you are concerned about basilar artery thrombosis, if the patient has focal deficits, or if the sequence of events is really concerning for this kind of presentation, please get a CTA and inform a stroke specialist if it's occluded as soon as possible. And finally, a broader definition of TIA incorporating all this knowledge could lead to more referrals of TIA mimics for assessment with either imaging MRI, CTAs, carotid artery ultrasounds, but also will increase the need for service provision to all of these patients. And to conclude, we should always think of one rule. We must always listen to the patient, get a very good history, because most of the time the patient is telling us the diagnosis. So first and foremost, we should take a very good history. And then the next step is a very good clinical exam. And the third step is the imaging. Thank you so much for your attention. And I'm really looking forward to the discussion.
Thank you so much, Dr. Costanos, for that very comprehensive presentation. Are there any questions from the group? You can either unmute yourself or include them in the chat. Okay, so the question is, should the hints
I think it was grading service, Gary. Thank you. I just wanted to say it was beautiful. Thank you. It was a great review for me. And
thanks. Yeah, I see a question here if this hints exam.
lots of new knowledge.
Yeah, I don't know if you can hear me.
Yes, we can hear you, Dr. Costanos.
Oh, okay, great. Yeah, I think someone was trying to pose a question, but I wasn't able to hear the exact question. Maybe you can write it down in the chat. I see here a question in the chat box. If the HINTS exam, it can only be performed by physicians or also by allied healthcare professionals. I think like for every test that is non-invasive, which is like a screening test, it should be performed by whoever is trained to do that, right? So HINTS exam might look kind of easy to do, but I can tell you it's not easy at all. And as I told you, the publication in Stroke, this study was performed by a neuro-ophthalmologist. So I think that every test that we do, we should be really confident that we are able to do it correctly and to be able to interpret the findings as we should. because it can be a double-edged sword. And I can tell you, you can try it, but it's really challenging to do a proper hinge exam, because most of the patients, because they have vertigo, they are not so cooperative. So they're closing their eyes when you're turning them, and you know, it's not easy, very easy to do.
Any other questions from the group? So I have a couple while we're waiting for others to come up. So if we're looking at patients with that we're triaging in the ED, and so as you say, the FAST doesn't really help us as we're going. I really liked your sort of 5 Ds, but again, I think as you're saying, would you suggest sort of that FAST, but plus ataxia and a visual deficit is sort of being those cues to think about in those patients that are not presenting in the standard way? If you're the triage nurses, or what are those key things to say, I need to capture this? This is not my typical person.
Yeah, so that's a great question, Rhonda. So it's really challenging, and honestly, that's why I put this in my presentation. And every neurologist that you will ask, he has been fooled by one way or the other. So it's really challenging. But what I can say is that if you are concerned, if you think about posterior circulation stroke, just forget about the FAST. Look the patient in the eyes. Look for visual field deficits. Look for nystagmus. And if the patient is not able to get out of the stretcher because he's feeling dizzy and he has vertigo, be really concerned. And you know, if you think that the symptoms could be related to posterior circulation ischemia, it's not unreasonable to ask for vascular imaging. And the reason for that is that if you see a stenosis in the basilar or in the vertebral artery, there is a higher likelihood that this patient is indeed suffering from a stroke or a TIA. And of course, if you see, like, you know, a clot in the basilar or a clot hanging in there, it will have also consequences for the management of this patient. So I would suggest clinical history, really good clinical history, proper neurological examination, focusing on the visual fields, ataxia, and the gaze, and you know, have a low threshold to ask for imaging. Spend some more time with the patient.
Great. And so I guess the other question would be looking at in the hyperacute, would you be looking at sort of that CT-CTA, or would you be looking at getting a very rapid MRI? Or what would sort of your first line in that workup be?
So if the patient presents in the time window where we can do something, right, we can like thrombolyze or go for endovascular thrombectomy, I would say that CT-CTA is the way to go. So if the patient is outside of any treatment window and we are just, you know, want to establish a diagnosis, then we can like lower the gears and ask for an MRI.
There are a couple of questions in the chat, so I'm just going to go up. Many of these patients have debilitating nausea, dizziness. Do you have any tips on symptom management?
Yeah, I would say go really slowly. Give something that's not sedating for the patients, because, you know, when you're concerned about damage to the brain, you don't want any like sedating stuff to mess around. So I say start slowly with some gravel, like small doses, and just take a quick look at the patient, you know, see how he's doing. And then, of course, you know, when you have more confident and the patient, you know, is like outside of the acute time period, you have like many other options to escalate the treatment for the dizziness and the vertigo. But first, you know, be mindful not to sedate the patient. So it's really important for a neurologist to be able to have the patient awake and to do serial you know, examinations and see if anything changed.
So there's another question. Are there specialized training people can engage in? For example, I'm an OT at a hospital without a neuro-ophthalmologist to do sort of those hints and other exams.
Yeah, so I think like any neurologist should be able to do a hints exam. And I think emergency physicians should be pretty confident doing that. So I think hints is a matter of training mostly, and we should be really confident in performing hints for the patients that they come with dizziness, vertigo, and they have nystagmus.
Comment, excellent presentation. Would you suggest a CT perfusion on a hyperacute phase in the ED with positive visual deficits plus dizziness?
Yeah, so if you have visual deficits, I think the CT perfusion might help you because you're thinking mostly about like a PCA infract. So the honest truth is that if you get a CTA, if you follow the vessels, most likely you will be able to find the occlusion of the vessel, but that takes time. You need to go to every little vessel and see if they are if they are occluded. But if you get a perfusion, you'll be able to see the deficit. The tricky point here, as I said earlier, is that a patient that has neurological findings, as this patient that has visual deficits and dizziness, if you do a CT perfusion and this is negative, so you don't find any perfusion deficits, disregard it. This doesn't mean that the patient does not have a stroke. And there is a bunch of reasons why perfusion might be negative. One of them is that the patient might have a lacunar stroke and not affecting a big vessel in the brain that gives you this perfusion deficit. So I would say that it is a useful tool to have, but you should be really mindful about the drawbacks that this technique has.
One more question in the chat, and then I'll open it up on for anyone online, is can you explain causes for when a person describes that they are spinning versus that the environment is spinning?
Yeah, so that's an excellent question. So I can tell you that both of these, they classify under the umbrella of vertigo. So if a patient tells you that he's spinning around the environment or the environment is spinning around him, you should be concerned that this is a vertigo and look in the ear and the brain. Vertigo is that we are moving, when we have the environment as a reference to us. So yeah, those two things are vertigo, and we should be really cautious when the patient describes one or the other.
Are there any other questions from the group? So Dr. Costanos, I have one. Well, is sometimes when we see with our patients who have the posterior, the basilar artery strokes, we tend to see sort of that stuttering and starting symptoms. So they'll have sort of weakness, they may improve or they may progress. Are those typical presentations we tend to see, and are there key things we should look at?
Yeah, so there are, this is an excellent question. So there are like two types of presentations. There are patients with preceding symptoms that they have the stuttering, a bit of dysarthria, a bit like off balance, and then they have basilar syndrome and they fall unconscious, and they have the patient without precipitating symptoms. So it's not uncommon, but it's really so hard to diagnose it and act like beforehand. Most of the times we do like an ad hoc diagnosis. We see a patient that has a confirmed basilar artery because he's doing really poorly, and then his wife described, oh, like 2 days ago he has this stuttering, he had a little bit of ataxia on the gait. So when we hear that, we should be like really careful, but it's a big chameleon. It's so hard. I mean, like for the patients to seek for medical attention, and for the physicians to have in their differential diagnosis, oh, this might be something that's really important, and maybe this guy's just throwing clots up in the basilar. Yeah, so that's an excellent question. So as physicians, we should be really mindful when we have these patients and get a clear history. So if you get a good history and we do a good neurological exam, and again, in this case, I would have, again, a really low threshold to go for imaging.
Any questions from the group? Thank you. I'm going to take silence. It was an excellent presentation, Dr. Stamos. Great coverage of a lot of very challenging and difficult presentations, and lots of great tools for us to take away. I really love the 5Ds. I like, some of that very much looking at the eyes, that visual, the ataxia. So a lot of great tips for us to take away and implement really into our practice, which is exactly what we're really hoping for with sort of our presentations, is really looking to say, what can I use, this afternoon in my practice? So thank you very much for your excellent presentation. I'm going to then move over now and introduce our next speaker. Sorry. I'll share my screen. So it is my pleasure to introduce Dr. Christine Hawks, who recently completed her interventional neuroradiology clinical fellowship at McMaster University, training to perform interventions like mechanical thrombectomy for acute stroke. She also finished a clinical fellowship in vascular neurology at the University of Pittsburgh Medical Center in 2019, one of the highest volume stroke centers in the US. Prior to her fellowship, she completed her training in adult neurology at McMaster University in 2018. Christine will be starting a position at Sunnybrook Health Sciences Center as a stroke neurologist and interventional neuroradiologist this fall. And so it is my pleasure to pass it over to Christine, who is really going to share with us hyperacute management of posterior circulation stroke. So thank you, Christine.
Thank you so much for the kind introduction, Rhonda, and thank you to the committee that has allowed me to be here today to present. And as well, thank you to Dr. Katsanos for setting the stage and doing a lot of the heavy lifting on this topic. So I'm going to be talking today about what do we actually do to manage these patients. We've identified a posterior circulation stroke. What are the treatment options available? The objectives will first introduce the topic using a quick case and try to get some interaction with a poll, hopefully that will work. And then we'll discuss some of the treatment options for posterior circulation ischemic strokes. And I'm hoping to incorporate some of the Canadian stroke best practices guidelines that can be found on their website. So that can be an excellent reference for you in the future. So to start off, we'll talk about thrombolysis, and then we'll talk about some other medical therapies. And then finally, we'll talk about my personal favorite topic, endovascular treatment. I don't have any disclosures. I agree with Dr. Katsanos. I've also been fooled by posterior circulation strokes as well, so I've been burned. So let's start off with a case. So this is a 53-year-old man, history of a remote stroke. The exact stroke symptoms were not known at the time that he presented. He had a history of hypertension, coronary artery disease, and sleep apnea. He was last seen normal by his wife the day prior to when he was found at 2000 hours. And then 0430 hours, his wife found him on the floor in the bathroom, unconscious, not responding to her. And she thought maybe he was weaker on the left side, but not clear. So based on this, here's our first polling question. What is the most likely diagnosis? Anterior circulation ischemic stroke, posterior circulation ischemic stroke, intracerebral hemorrhage, toxic, metabolic, or infectious encephalopathy, or we don't have enough information yet. Let's see if we can launch the poll. For some reason, it's not letting me launch the poll.
Dr. Hawks, it's been launched. You may not see it because you're
Perfect.
presenting. We've had 23 responses so far.
Wonderful.
I may have ended the poll too soon.
That's probably okay.
Can you see, can people see the responses?
Yes, I can. I don't know, Dr. Hawks, if you can see.
I'm not able to see the responses, but I'm gonna go ahead and show you my response to this.
Most people
and then
did
you guys can
put-
compare.
Most people responded, 83% responded, not enough information.
Perfect. I totally agree. Even though this is a talk on posterior circulation strokes, at this point in time, we don't have enough information from what I've given you. So I'm going to go ahead and give you a little bit more information now. And the point here is basically when someone's found unconscious, there's a really wide differential of what could cause this, including all of these things that you see listed here, neurologic, metabolic, and other etiologies. And ischemic stroke is only one small part of this. In fact, basilar artery occlusion, which is the most severe form of posterior circulation stroke, only accounts for 1% of acute ischemic stroke. And when we're looking at all large vessel occlusions, including the anterior and the posterior circulation, it only accounts for about 5%. So this is a rare etiology, but even though it's rare, it's a treatable etiology. And so it should be something that we're all aware of because we don't want to miss the opportunity to treat someone with a basilar artery occlusion. So let's get a little bit more information. So this patient was evaluated in the emergency department. An NIH stroke scale was done. The number came up with 23, big high number. And basically the patient was obtunded, not speaking, not obeying, with a right facial droop and left greater than right weakness. So some bilateral symptoms, some cross findings, as Dr. Katsanos pointed out, that should make us now think posterior circulation. And here was the initial CT. We don't see any obvious hemorrhage. We don't see any obvious hypodensity anywhere other than a few probably chronic areas of hypodensity in the anterior circulation. We see a couple of small areas of hypodensity in the cerebellum. So maybe these were what the family had told us about as the previous strokes. And then the patient appropriately went on to have a CT angiogram. So I'm going to slow it down here. Now we're really thinking this is a posterior circulation stroke syndrome based on all of those red flags, as well as the CT not showing an obvious hemorrhage or another obvious etiology. So here we're following the vertebral arteries, paying close attention to them as they come up through the V3, V4 segments. So now the vertebral arteries have gone intracranial and intradural at this point. So they should be joining together here to form the basilar artery. And we basically lose where we were following that contrast. So that's what a basilar occlusion looks like. And we still don't see any contrast filling where the basilar artery should be. And now we see it back again. So we see that there's some reconstitution of the basilar artery distally. And the posterior cerebral arteries are patent. And the rest of the intracranial vessels are open. So that's what a basilar artery occlusion looks like. I won't launch the poll again for this one because I think now it's all going to be obvious to you that this is what I'm talking about in terms of a posterior circulation ischemic stroke. And specifically, this is a subtype, this is a basilar occlusion. So this one, Barb, if you're able to help me launch the poll for this, what is the treatment? So A, thrombolysis, meaning TPA or TNK, B, endovascular treatment, thrombectomy, C, both A and B, D, none, there's nothing we can do, or E, consult with a stroke expert and an interventionalist.
Just 1 second, I have to figure out how to go to the next poll. I did make more than one. Oh, got it.
While you're bringing that up, can I just clarify? I can't remember. When was the person last seen normal?
The day before. So within 24 hours, but beyond 4.5 hours.
We'll give it 10 more seconds. Get your answer in. Don't be shy. It's anonymous. So if you can't see Dr. Hawks, it's 81% of people chose E.
Okay, great. Perfect. That's what I was thinking as well. So I would call Dr. Katsanos or your local stroke expert and also your interventionalist in the area. That's perfect. And we'll talk about all of the different treatment options and then I'll come back to this case at the end. So let's first talk about thrombolysis. Here's a picture of what TPA actually looks like, but when I refer to thrombolysis, nowadays I mean both TPA and TNK. So at some centers, both are available, at some centers only TPA. And the field is continuing to move forward when we talk about thrombolysis and different treatment options. Here's what the Canadian stroke best practices say from 2018. Here are the straightforward inclusion criteria. So a patient that you suspect has an ischemic stroke and the deficits that are caused are disabling. When I say disabling, I mean the symptoms are causing some sort of impairment, and that can be different for different patients. So that's kind of the patient-centered approach. And the time from last known well or last seen normal is less than 4.5 hours. There are some absolute and some relative exclusion criteria. These are also all from the Canadian stroke best practices. But the basic idea is that this is a clot busting medicine. So anything that would put the patient at increased risk of a hemorrhagic complication is something that is likely a relative exclusion criteria. The absolute exclusion is any obvious ongoing hemorrhage at the time that you're seeing the patient. So hemorrhage on the scan, or they're having a hemorrhage in front of you from some other bleeding source. And as Dr. Katsanos already went over in a lot of detail, these are why posterior circulation strokes are more difficult to identify. They don't always present with what we think of as the typical stroke symptoms. So things like facial droop, unilateral weakness, unilateral numbness, aphasia, gaze preference, though they can, and vision loss. The more like the 5 Ds that he recommended are in the category of posterior circulation symptoms, and we need to be aware that they can also cross over. So you can have a combination of all of these symptoms, both the typical stroke symptoms and the less typical posterior circulation symptoms. Another factor to consider is that when patients present with posterior circulation strokes, and specifically basilar artery occlusions, they don't always present in the typical way that we think of with the acute onset, though they can. And this is what a typical stroke patient might present with: being totally normal, was seen by someone or was known to be normal at a certain time point, and then had an obvious sudden onset of a deficit. About 1/3 of patients with basilar artery occlusion can present somewhat like this, where they're normal for a period of time and then they have stuttering symptoms or fluctuating symptoms, sometimes resolving completely and sometimes not. So the picture isn't always as clear about when the last known well or last seen normal actually was. And sometimes it can even present like a sort of progressive picture. So that's another thing that can be a challenge when trying to figure out whether this person is a candidate for any sort of treatment. So just to reiterate, what are the challenges in the posterior circulation versus the anterior circulation for thrombolysis? Well, the biggest one is that there can be a delay in diagnosis, and that can lead to a delay in initiation of thrombolysis, or the patient may not be a candidate for thrombolysis because they're presenting outside of that time window. This can happen in the field, it can happen in the emergency department, or it can even happen with a neurologist. Like we've said, we've all been fooled by someone that we didn't think was having a stroke, and it turns out it was a subtle syndrome that we missed. And as was mentioned, the NIH doesn't fully represent the posterior stroke symptoms. So here's an example. So this was a lady that I saw a couple weeks ago when I was on service, 63-year-old woman, history of hypertension. She was at home with her husband in the morning and was making breakfast in the kitchen. She bent over to try to put some dishes away and suddenly developed dizziness after she sort of stood back up. So maybe not right away would that be a red flag for a posterior stroke syndrome, but she and her husband knew that something was wrong and they called EMS. By the time they arrived, her dizziness symptom had completely resolved. So she was brought to the local emergency department, not the stroke center, not Hamilton General. And she was triaged as a TIA because her symptoms had resolved completely at that time. But when she was seen by the emergency room physician astutely identified that she did in fact have a visual field cut and some mild left-sided weakness. So she wasn't fully drifting, but there was some subtle sign that there was some weakness on the left side. So then we transferred her to Hamilton General Hospital. And when we examined her, she did in fact have a full left homonymous hemianopsia. She had some subtle drift on the left side and some mild numbness. So her NIH stroke scale was 5. She got a CT head and a CTA as per our usual stroke protocol, and she was able to receive IV TPA. But as you can see, because things were a little bit more confusing and it wasn't an obvious stroke syndrome to begin with, it took longer than what it could have been if she had come directly to us. What about safety? That's the most important part about any treatment. So is it something that's safe? Well, at least as safe as the anterior circulation. When we look at big studies of patients presenting with stroke who've received thrombolysis, at least as safe, if not even slightly safer for the posterior circulation. And we'll talk about this more in a few minutes, but we saw this in large trials like the BASICS trial in patients even presenting with a lower NIH stroke scale. And nowadays, the window for thrombolysis, just like the window for endovascular treatment, is also expanding. This isn't something that is done everywhere, and it's definitely not something that I recommend in places where there's no stroke specialist, but there have been randomized controlled trials looking at using the tissue window, meaning not just the time frame, to determine whether someone is a candidate for thrombolysis. So this means looking at an MRI and deciding whether there's a mismatch between the tissue that's completely infarcted, so as a surrogate using the restricted diffusion, and tissue that's still at risk of infarcting. Again, this is not something that's available at all centers and definitely across Canada with the resource issues that we have. MRI in the acute setting is not something that's feasible everywhere, and if anything is quite rare, and it definitely requires a stroke neurologist input. But I just wanted to mention that the world in stroke is changing, and we're now thinking more about using things like tissue window rather than time alone to determine whether someone's a candidate for therapy. And we're also moving towards using other agents. So TPA is the standard of care, that's in the Canadian Stroke Best Practices, but TNK, a newer agent, is also being used. And there's some evidence that it has been shown to have higher reperfusion than TPA in some studies. And because it is given as a bolus and doesn't have the 1 hour infusion like TPA does, it's logistically easier. And in some studies, that's translated to a shorter time to patients going from thrombolysis to the angio suite for thrombectomy, with no trade-off in terms of safety. If anything, it seems perhaps even slightly safer. So let's move on now, changing gears a little bit, to what are the other medical therapies that can be offered to these patients. Unfortunately, some patients present and are not candidates for thrombolysis because they're on anticoagulants, or they have active bleeding going on, or they're outside the time windows that are in the Canadian stroke best practices. So antiplatelet agents are the mainstay of treatment in subacute posterior circulation strokes, just like in the anterior circulation. And they're used when patients are not a candidate for thrombolysis or thrombectomy, and you're not planning on starting anticoagulation, which we'll talk about in a second. So these are the patients that present and their symptoms have truly resolved, or they present a few days after their symptoms and they have an established infarct on imaging. And with the advancements in antiplatelet agents, more and more we're using combinations of antiplatelet agents like aspirin and clopidogrel or dual antiplatelet therapy, especially in patients that have presented with minor strokes or completely resolved symptoms. And there are also specific therapies geared towards the etiology of the stroke. So once the patient's etiology has been identified, then we can tailor the treatment specifically towards that etiology. So for example, intracranial atherosclerotic disease is a fairly common cause of posterior circulation stroke, as Dr. Katsanos pointed out. And the standard approach is dual antiplatelet therapy, usually for 3 months, and a high-dose statin, as well as lifestyle modification. This is based on the Sampras trial, but there's ongoing research in PHRI. One of the stroke neurologists, Dr. Pereira, is researching this with other stroke neurologists and looking at whether anticoagulation is perhaps an even better treatment option in these patients after that standard treatment. And then, of course, if you find a cardiobolic source, then typically anticoagulation is the appropriate treatment. For example, if the patient has atrial fibrillation. And then in the posterior circulation, dissection is also a fairly common cause. And we typically use antiplatelet agents for dissection as well, and then perform some follow-up imaging in the future to decide on continuing or altering therapy based on how the dissection is healing. So let's talk a little bit about IV heparin. This is still somewhat of a controversial topic in basilar artery thrombus. If you brought together a bunch of stroke neurologists, they might all have differing opinions about who they would start IV heparin in and when they would stop it and how long they would treat for. But it comes down to a clinical decision. And typically we use IV heparin in patients who are presenting with a low NIH stroke scale, meaning they're someone that's not going for endovascular treatment, meaning they have sort of minimal deficits, and they're not someone who's receiving IV TPA. Obviously, someone who's receiving IV TPA should absolutely not receive IV heparin. And sometimes that's because a patient presents outside the TPA window. We find this basilar thrombus seen here on the CT. We decide that the risks outweigh the benefits, or the benefits outweigh the risks, and we start them on IV heparin. It requires close clinical monitoring. So usually these patients have to be in some sort of neuro monitoring area where they can have frequent neurovitals done. And if they were to worsen, then the team will typically reevaluate whether, in fact, they should now go for endovascular treatment. And this is the typical donut sign that we can see with a basilar thrombus, or sometimes called a free-floating thrombus. We see that there's contrast around in the basilar artery, and then centrally, there's an area where the contrast is not filling, or a filling defect, and that's sometimes called a donut sign. So let's talk about endovascular treatment now, sometimes called EVT or mechanical thrombectomy, or going to the cath lab. The techniques that we use in modern endovascular treatment were actually first developed for use in the posterior circulation with basilar artery occlusions, because these patients present with the most severe deficits and have the poorest prognosis. People were desperate to try to treat them and decided to try different endovascular techniques, like injecting thrombolytic agents into the posterior circulation, or what we use now in both the anterior and posterior circulation, using devices to try to aspirate out the clot. Here's a little video. This is the anterior circulation, but just to show you what this might look like for those that haven't seen a procedure. So just to point out a couple of things. One is that we don't usually use this type of balloon catheter in the posterior circulation because we're having to go into a vertebral artery and it's significantly smaller than the carotid artery. So we typically don't use a balloon guide catheter. And we usually use an aspiration catheter, so kind of like a tiny suction or vacuum cleaner, and bring it up to the face of the clot as well. So what are the Canadian stroke best practice guidelines saying about basilar artery occlusions? They say that the decision to treat comes down to the expertise of stroke neurologists as well as the neurointerventionalists, because these are difficult decisions to make, and because the evidence is not as clear in the posterior circulation as it is in the anterior circulation. Well, what is the evidence for EVT in the posterior circulation? Posterior circulation strokes were not included in all of the big trials from 2015 and beyond that looked at anterior circulation large vessel occlusion. So all of the trials that you're probably familiar with excluded patients with basilar artery occlusions and only focused on ICA occlusions or MCA occlusions. While there is some evidence from some randomized controlled trials that looked at specifically basilar artery occlusions, and this is one of them. This was published in 2019 called the BEST trial. And they basically looked at endovascular treatment versus medical treatment for basilar artery occlusions. And it was open label. So the patients that went for thrombectomy, they knew that they went for thrombectomy. And it was unfortunately stopped early. And their primary outcome was looking at 90-day MRS, or patients that at 90 days had what they determined to be a good outcome, and they found no significant difference. Unfortunately, there were several problems with this. When they looked at patients who actually received the treatment that they were supposed to receive, so whether that was intervention or no intervention, there was a significant difference. So in the patients who did receive EVT, the final MRS at 90 days, 44% had an MRS of 0 to 3. And in the control arm, the people that didn't go for endovascular treatment, only 25%. But that's not how the trial was set up. It was set up as an intention to treat, which is how most randomized controlled trials are set up. So it was overall called a negative trial. Another trial came out shortly after, looking at a similar question, basilar artery occlusions with endovascular treatment versus medical management alone. And a high portion of the patients that had medical management received IV TPA. And they also found no significant difference in their primary outcome. And they interestingly thought that maybe there was a better than expected outcome in the people that received best medical management, because there was a very efficient and high use of TPA. And they found that there was a subgroup who perhaps did benefit from EVT, and that was patients who had a high NIH stroke scale, so a very severe exam, and proposed that perhaps in those patients, we should still be considering EVT. And I definitely agree with that. Here are some of the issues in these trials. Number one, it's difficult to recruit patients into these trials because they're rare occurrence. And also towards the end of when these trials were being published, all of the other stroke trials for the anterior circulation had been published, and people were more geared towards going to the angio suite, meaning there was kind of a loss of equipoise. Clinicians who saw patients with basilar artery occlusion felt more strongly towards the end of these trials that they should go for endovascular treatment. And there was a significant crossover. So even though patients were assigned to not receive EVT, some of them did, and vice versa. There are a few ongoing trials trying to look at basilar artery occlusions in various ways, but most of these are done being done in China. And so boiling it down from my perspective, for basilar artery occlusions, they should be patients who have a significant deficit. So kind of along the lines of what the trialists from BASICS found, they should have a significant disabling deficit. Their subgroup was split into NIH greater than or less than 10, and that is reasonable. Plus, they need to have a reachable occlusion or a large vessel occlusion that technically can be amenable to treatment. Plus, the patient should have a reasonable baseline, just like when we're thinking about endovascular treatment for the anterior circulation, the patient's baseline function should be reasonably good. And the infarct should not be complete. So here's an example on the right of a CT scan showing an extensive infarct from a basilar artery occlusion. You can see that both PCA territories are infarcted. There's evidence of brainstem infarct, and you can also see that the cerebellum, there's some hypodensity there as well. And so this is likely a completed infarct. There are various scales and ways to look at how extensive the infarct is, but the bottom line is a big bad stroke like this, there's nothing that's going to bring that back. Opening the vessel is not going to be helpful in this type of situation. What about technique? So there have been no randomized controlled trials looking at the specific techniques used in endovascular treatment of basilar artery occlusions, but there is some registry data. So this is from the United States called STAR, and they divided the technique into aspiration alone, aspiration plus using a stent retriever, aspiration alone, stent retriever alone, or a combination. And though we might think that, okay, a combination is probably better than one or the other, in fact, in this registry, and this is observational, the aspiration alone was associated with a shorter procedure time and better outcomes. And that may have to do with the types of occlusions that we see in the posterior circulation, where compared to the anterior circulation, there's a higher portion of intracranial atherosclerotic disease, and perhaps aspirating that clot is the best treatment rather than using a stent and dragging it across, but that kind of remains to be seen. So let's return to the case that we talked about at the beginning. So in this patient's case, just to remind you, this man presented as a wake-up stroke with an NIH of 23 and a basilar occlusion. We saw in the CTA that the occlusion started at the vertebrobasilar junction and that there was reconstitution of the distal basilar. So thinking back to what Dr. Kitsanos presented, so this was a kind of like a mid-basilar occlusion, and it wasn't like a top of the basilar syndrome. That makes me think that there might be something underlying, like an underlying stenosis, that would be the reason why the clot occurred at that location rather than a basilar, top of the basilar. So we decided to go with endovascular treatment. Though some stroke neurologists consider giving thrombolytics outside of the 4.5-hour window, we didn't in this case, and we didn't have access to a quick MRI we just brought him to the angio suite. So here's an injection into the left subclavian artery. So the catheters that we use for the endovascular treatment are down in the patient's aortic arch on this view. And here's the course that we would have to try to take to go up into the left vertebral artery. You can see it's really, really curvy, and it caused us a lot of challenge. So we had to switch. Usually for, I would say, 95% of endovascular stroke cases, we use ephemeral access. And this is one of the few rare situations where it's actually better to use the arm, use a radial access. It gave us a bit more support because we're coming from the subclavian artery, and it kind of constrains the catheter a little bit better than the aortic arch, where the catheters are really floppy, and allowed us to have a better angle to get into this very tortuous vertebral artery. And we did one pass using a stent with an aspiration device. And this is how the angiogram looked after. Here's an injection. This is the left vertebral artery. And you can see that it has this irregular appearance that's characteristic of some atherosclerotic disease. And then this severe stenosis, where the arrow is just at the vertebral basilar junction. That's where we saw the occlusion on the CTA. And now the distal basilar artery is completely open. We can see the PCAs, and he had a fetal PCA on the one side. That's why we don't see it on the right. And we can see the cerebellar arteries as well. But we see this tight stenosis. So this is suggestive of intracranial atherosclerotic disease, and this can be a big challenge. Sometimes in the case, even before our eyes, we see the stenosis for a second and then it reoccludes. So it often forces us to do kind of aggressive things and start treatment. And in this patient's case, we did start what's called integralin, which is an intravenous form of an antiplatelet agent, similar to clopidogrel. And that allowed us to keep that artery open. He was also loaded with aspirin in the angio suite, and then eventually loaded with clopidogrel. He did very well clinically. He was extubated about 48 hours later with an NIH of 4. And interestingly, when we went back and talked to him after he was awake and able to give us more of a story, there was a sudden change, like a high-pitched hearing sound that he had before he lost consciousness. So that goes towards what Dr. Katsanos said about any sort of acute change in hearing should also be a red flag that this could be a posterior circulation event. And in his case, that probably had to do with the anterior inferior cerebellar arteries being kind of the most distal territory in his case. And when those are affected, you can have changes in hearing. So here's his MRI. This is a DWI, so a small few hits of restricted diffusion in the right cerebellar hemisphere, here, a bit of haziness in the medial pons. So that could be an early evolving infarct or an incomplete infarct, because this MRI was done fairly early after he had the procedure. But otherwise, we don't see an extensive infarct, and clinically he did very well and was able to be discharged from the hospital. So here are my conclusions. Any posterior circulation stroke is a very challenging pathology. It's challenging to diagnose, and it's also challenging to treat, but thrombolysis works. It's the standard of care, and it's very safe in the posterior circulation. For severe posterior circulation strokes that are a large vessel occlusion, so basilar artery occlusion, and some people will consider a P1, the first segment of the posterior cerebral artery, a large vessel occlusion as well. Endovascular treatment is an option, but you won't know unless you ask. So you should be asking your stroke specialists and your interventionalists if you see someone that you think has a large vessel occlusion in the anterior or the posterior circulation, whether this person is a candidate for therapy, because we don't want to miss the opportunity to intervene. As we have said, that this is such a severe pathology and can have devastating effects, we should always be considering whether or not there's a treatment option available. Thank you. I'm happy to take any questions, and I'm interested to hear your comments as well.
Thank you so much, Dr. Hawks. Hopefully you can hear me. I heard that I am very quiet, which is not usually something people say about me. So hopefully you can hear me. Are there any questions for Dr. Hawks for her amazing presentation? So hi and thanks, excellent presentation. Thanks for the great presentation. So I have one question while people are thinking up their thoughts. So when we look at the posterior circulation, is there a different, I think as you've highlighted, really looking at that tissue window versus time window. Is there a time window we would think with endovascular therapy in sort of the expanded window with posterior circulation strokes? And what about perfusion versus MRI with posterior circulation strokes?
Yeah, those are great questions. I definitely would consider any patient with a basilar artery occlusion in the that's anywhere from 24 hours to even beyond, because sometimes these patients present with these stuttering symptoms or progressive symptoms, and they were not even like normal maybe more than 24 hours ago. So as long as there's still salvageable tissue, because this is such a severe and potentially life-threatening condition, I would consider treating them even beyond 24 hours. But technically in the guidelines, you know, the treatment, endovascular treatment should be offered up to 24 hours. As far as the tissue window, yes, I absolutely agree. For these patients, we should be looking at not just time, because time is really a surrogate for tissue. We should be looking at tissue. Unfortunately, CT is not the best way to look at tissue in the posterior circulation, but it gives us a crude estimate. So the ways that we look at tissue in the posterior circulation on CT are things like the posterior circulation aspects. So it basically is the aspect score, but for the posterior circulation. So that's one way. And there's others. There's other scoring systems that are more detailed. But MRI gives a better picture, but it's not available everywhere. And it is always at a cost of time. No matter what center you're at, whether it's a big fancy US center or it's a rural center, getting an MRI takes time more than a CT CTA. So in standard practice, a CT CTA should be a good enough way of evaluating these patients acutely. As far as CT perfusion goes, the brainstem is not very well imaged on CT perfusion, but you can get imaging that looks at, like what Dr. Cazzano showed, the PCA territories, and you can see the cerebellum as well. So it can be helpful, but it's not as established as CT perfusion is for the anterior circulation. Like, we don't use the same cutoffs of what we use in rapid in the anterior circulation. So it's a little bit more complicated and definitely requires consultation with your stroke specialist.
Perfect. Thanks, thanks, Dr. Hawks. There's a couple of questions in the chat. Dual antiplatelet therapy. Can you provide evidence beyond chance that requires dual antiplatelet beyond 21 days? Is there rationale beyond 21 days to go to 30 days?
Yeah, so that's a great question. So yeah, we use the CHANCE trial as well as the POINT trial. That was kind of the North American equivalent of the CHANCE trial that looked at dual antiplatelet therapy. And they kind of analyzed what's the best time point in terms of the risk benefit of dual antiplatelet therapy. When should we stop? And that's where the 21 days comes from. It comes from both of those trials. And for standard practice, someone who comes in with a TIA without intracranial atherosclerosis, I agree with using the 21-day recommendation. Sometimes we will use 3 months when we're looking at intracranial atherosclerosis. So when you identify on the CTA that there's a culprit ICAD lesion, then we'll usually keep patients on dual antiplatelet therapy for a little bit longer. That's based on the Sampras trial that used the 3-month time frame. But the Sampras trial didn't compare 21 days to 3 months. It just compared intervening with a stent to the medical management that included 3 months. So we don't have a direct comparison of apples to apples of 21 days versus 3 months, even for ICAD, but most people will tend to keep people on dual antiplatelet therapy a little bit longer when we find ICAD. So that's where that comes from.
Thank you. Thanks, Dr. Hawks. There's a couple more questions. Some CTA do not clearly discriminate between dissection and atherosclerotic etiology, especially with asymmetrical sizes to start. Does this change management acutely, chronically?
Yeah, that is a great point. CTA is good and has high spatial resolution, but it doesn't always 100% distinguish between an atherosclerotic lesion and a dissection, or a lesion that's due to some other etiology, like even a vasculitis. So there's other non-invasive imaging modalities that can sometimes be helpful, like MRI with vessel wall imaging that can sometimes be helpful in looking for the weird and wonderful vasculitis category, but also MRI with a dissection protocol can sometimes be helpful in determining whether it's a dissection rather than an atherosclerotic lesion. But even that's not perfect. The gold standard would be a diagnostic cerebral angiogram, but that's the most invasive form of imaging that we have, and it's not available everywhere. The bottom line is, though, that typically the treatment is antiplatelet agents, whether it's dissection or atherosclerotic disease. And if they are presenting with minor symptoms or resolved symptoms and would be someone that would have fit in chance or point, then I typically do dual antiplatelet therapy. And if they're more complicated than that, then it's always a risk benefit calculation that you have to do, and it's kind of patient by patient. So it doesn't necessarily change the initial treatment unless you see something that's like more looking like a thrombus on top of whatever the atherosclerotic or dissection lesion is, then you might consider anticoagulation. But yes, you're right. CTA is not perfect, and there's sometimes these lesions that you ask multiple neuroradiologists, and even amongst them, they can't for sure tell you it's a dissection or it's an atherosclerotic lesion.
There's another question. How often, if ever, anymore, would Agrinox be used in place of ASA and Plavix?
Almost never. For me, I don't know, Dr. Katsanos, if he's still on, can say whether he's prescribed Agrinox recently, but I have not. The main reason for that, that it's fallen out of favor, is that it does have side effects like headache. And then if people get headaches and they don't take it, then it's not going to be useful to them. So aspirin and Plavix are the mainstay antiplatelet agents. Sometimes people will use ticagrelor, which is the non-prodrug version of Plavix or clopidogrel, because there are certain patients who are Plavix non-responders, and ticagrelor takes away that problem. But it does have its other problems. So ticagrelor is BID dosing, so compliance issues come up. It can cause shortness of breath as a side effect, so that can come up, and it's also more expensive. So that's why the main two that we go to are aspirin and Plavix, and not other agents typically.
Are there any other questions for Dr. Hawks from the audience? Okay, I'm going to pause and just thank both of our speakers, but thank Dr. Hawks for her great presentation on the hyperacute management of posterior circulation strokes, and thanking Dr. Costanos for really providing that overview of identification and recognition and the hyperacute workup of posterior circulation strokes. Barb has posted in the chat the link to the Survey Monkey to complete the evaluation form. Also, that link will be sent to participants. Is that correct, Barb, for people to complete?
Yes, I'm going to try to send it through Zoom. I don't know if I can because it's a past event, but you will find it on the website as well. I'm going to send it to you as many ways as possible because we really do value your feedback. If you visit our website and look into past education materials after this, You're going to find the video in a couple of days for this presentation or both presentations. I'm going to take another look for sure. And we'll also have the certificate of attendance there for you to complete, as well as the evaluation. Thank you.
Dr. Hawks, can you stop sharing your screen for 1 minute? So I am just going to share my screen. Usually if I can get to slideshow. So I just wanted to let people know, as I said at the beginning, this is the first of a 6-part series that Central South is focusing on posterior circulation strokes. Our next presentation is part 2 is management of posterior circulation strokes with Dr. Demetrios Salas and Dr. Florin Feliu on September the 28th. That is also a 2-hour session from 12 until 2. That will focus on walking through some of the posterior circulation syndromes, but also talking about doing some of that symptom management, preparing that patient to participate in rehabilitation. The final 4 parts in our series are webinars and are focusing on the common, some of the posterior stroke sequelae that we see with these patients. So on November the 2nd, from 12 until 1:30, Dr. Mary Warren is going to focus on hemianopia, the hidden impairment following posterior circulation strokes, functional limitations, assessment, and intervention. On November the 16th, from 12 until 1, Elizabeth Crawford, who is from the Vestibular Clinic in Toronto, is focusing on vertigo and dizziness after posterior circulation stroke. On November the 23rd, Dr. Katrina Steele will focus on dysphagia following posterior circulation stroke. And finally, on December the 7th, Dr. Vince DePaul will focus on ataxia following posterior circulation stroke. So a focus of those sessions are really looking at how do we manage this sequelae across the continuum of care, from acute, inpatient rehab, outpatient rehab, and also into the community. To register for these events, as Barbara said, you can go to our Central South Regional Stroke Network website, so csnstroke.ca. If you select educational events and go to the calendar, if you click on the date on the calendar and the event, you will be able to register for all of these webinar events. And as Barbara said, we will be posting the 2 presentations from today on the website, but also posting a recording of this session. So it'll be available for you later. So I just want to thank everyone for your participation and attendance in this session. Really hope that you will complete the evaluation forms and get your feedback. As a regional stroke network and education committee, we really look for your feedback to help our planning for our education events for the region based on the feedback from these workshops. So thank you everyone for a great presentation. Thanks to our 2 speakers. Thank you to the planning committee, and thanks to our participation, our participants for your attention in this event. Have a great day.